In a previous video, I showed a classical example of microcystic adnexal carcinoma that was shared with me by Corey Georgeson. And in this one, I'm going to show another example that was kindly shared with me by Antonina Kalmykova of CSD Healthcare in Kyiv. The patient was a 60-year-old female who presented with a 1 centimeter diameter tumor on the lip, and there were several fragments of tissue, none of which unfortunately had any overlying squamous epithelium, but I don't think that matters too much. What we can see is dense fibrous tissue infiltrated by a tumor which extends down into subcutaneous fat and in fact involves skeletal muscle at the base. And we can see at this scanning magnification that the tumor presents as little nodules scattered throughout the connective tissue. So let's have a look at this at slightly higher magnification. And here we can see a number of features. Firstly, we can see that there is some keratinization. There's a focus there, and I think there is more elsewhere. Yes, so there's keratinization there and there. So if you like, there are very small numbers of keratocysts. And then we can focus on the epithelial component, and this forms rather solid aggregates of cells, which we'll look at in higher magnification. The cells appear very uniform. They're small. They have central oval to vesicular nuclei, sometimes with small nucleoli. And the cytoplasm varies from palely eosinophilic through to clear cell cytoplasm, the latter perhaps suggesting the presence of glycogen. And here's a nice focus of keratinization with lamellae in that field. Now I want to go down to a lower magnification again just to show you other features. There's something we need to focus on there. There's a small nerve fiber with tumor growing alongside it, so we know there's perineural infiltration, which is not going to be good news for the patient. And let's see what else we've got. Here I think we can see more clear cell change. I just want to enlarge that. So if you like, the tumor is sort of biphasic. It's got more basaloid cells with not so much cytoplasm, and then larger cells with abundant clear cytoplasm, as you see there. Now, this tumor provoked quite a bit of conversation as to what it might represent. Some folk thought it could be an odd squamous carcinoma. I was struck by the basaloid component and the clear cell change, and I was wondering whether this might be a trichoblastic carcinoma, but I couldn't see any convincing stroma, so or follicular type stroma, and so that made that diagnosis a little bit less than likely. Now, to give Antonina great credit, she decided she thought this was a microcystic adnexal carcinoma, and I think she's quite right. and more power to her. It was a jolly good diagnosis. When one hunts around, one comes across these structures here where there's a vacuole with a rather nice hyaline membrane around it. They're forming a double one. I think that's probably a duct. The only option is it could be that it's incorporated the edge of some fat cells, and I can't dispute that. But there's another one there. And again, we've got this very nice membrane around it. So I think it's worth wondering about whether those are ducts. So to summarize, we have a tumor composed of solid nodules of cells that are accompanied by a very dense fibrous stroma. The tumor is invading fat. It's also extending and going through muscle. So incidentally, it's present at all of the margins of these pieces of tissue. It's showing perineural infiltration, and the possibility is that it might represent a variant of microcystic adnexal carcinoma. Now, if that was the case, what variant would this be? And I think it fits quite nicely with the solid variant of microcystic adnexal carcinoma, sometimes called solid tumor of the skin. And this is incredibly rare, more often than not. The differential of solid variant, I think it is a trichoblastic tumor, but in the absence of any specific follicular stroma, one's a bit stuck on that diagnosis. Now, we did some immunohistochemistry on this case, so let's have a look and see what they show. So that was the first one we'll look at is CK5, so cytokeratin 5, and this is strikingly positive. If we just look at it at a higher magnification. Now, what's quite interesting to me is that the tumor nodules are positive, but only in part. And it seems to me that the more basaloid component is the bit that's expressing CK5, whereas the clear cell elements are negative. Now, I'm not sure that I know exactly what that means, and perhaps if there are any of you watching who are experts in keratin immunohistochemistry, you might like to add a comment to the post, just so that we can all learn from your experience. Anyway, so CK5 is positive, and then we have P63, and again, even at this scanning magnification, we can see that it's strikingly positive. I'll go back down to a lower magnification. I've lost the tumor. There we are. Well, you can see it at that magnification. There is very strong positivity, and the immunoprofile of CK5 and P63 fits very nicely with a microcystic adnexal carcinoma. And then lastly, we have CK7, which in theory should be positive in a microcystic adnexal carcinoma, but this tumor is strikingly negative. So that, if you like, is a pointer against microcystic adnexal carcinoma. Now, I have a small single image PowerPoint that I wanted to show, because yes, whoops, sorry about that. We had some additional immunohistochemistry, but it's not on the scanner. And on the left, we have CEA, which showed very focal positivity. And in this bottom left corner, I think I'm fairly convinced this is a good duct with a nice sharp emer border, as you see there. That one's a bit uncertain. It's positive, and I'm not sure whether that isn't picking up keratin. It's difficult. And this is emer. Now, I thought that might be a duct in the middle of that clump of cells there, but I wasn't so sure about the bottom or the top as to whether these were in fact foci of keratinization. And there, on the top right, you can see those little ducts that I noticed when we were looking at the scan slide. And this is the immunohistochemistry for microcystic adnexal carcinoma. Consistently positive is CK5, CK6, CK7, but ours is CK7 negative. 100% of cases are P63 positive, which works for ours. And ductal differentiation can be identified with emer and CEA. And for those cases that one's wondering whether it's a desmoplastic trichoepithelioma, it's useful to note that MAC is consistently BER-EP4 negative, and it doesn't contain Merkel cells, as would be seen with a CK20. So I think all in all, the evidence is strongly in favor of Antonina's diagnosis of solid variant of microcystic adnexal carcinoma. Now, when MAC was first described, it was thought to be a low-grade ductal tumor of eccrine derivation, and I think this has been called into question with a variety of observations in MAC. Sometimes you get sebaceous differentiation, and sometimes you can in fact see follicular differentiation. And so the tumor is nowadays considered more to be a tumor of the follicular sebaceous unit. Now, the important thing about MAC is, although it's regarded as a low-grade sweat gland carcinoma, and low-grade implying lack of metastatic potential, that does not mean that it doesn't have a potential very high morbidity. The tumor shows somewhere between 40 and 60% recurrence rates. And this is because it's extremely hard to identify the border of the tumor. When you examine a patient clinically, it may appear as, let's say, a 1 centimeter diameter nodule, but in reality, that tumor might well be 2 centimeters in diameter in the flesh, and so it's difficult to excise them. I think that this is probably, particularly as most of these tumors occur on the face, I think Mohs surgery is really the treatment of choice. It's not that it has any greater success in terms of recurrence than plastic surgery. It just enables you to spare tissue, and the patient has less residual deformity from the surgery. Now, there are 2 or 3 cases in the literature where MAC has been reported with metastatic spread. The most recent one didn't have any histology at all, so I have no idea what that diagnosis really was. And I'm a bit skeptical. I've never seen a metastatic microcystic adnexal carcinoma, and I don't know anybody else who ever has either. So I suspect that it's reasonably safe to say that although the tumor has very significant recurrence rates, its metastatic potential is vanishingly rare. I hope this video has been of some use to you. Thank you very much.